today's PCOS e-awareness webinar. The aim of today's webinar is to discuss the diagnostic dilemmas, management challenges, and the recent updates on PCOS. On the top of this, we wish to spread the awareness among the general population about polycystic ovary syndrome to our doctor community and medical personnel. And I'm extremely happy to announce that today we have 5 eminent infertility specialists of Bangladesh and India as speakers and moderator of this webinar. And I'm pleased to introduce a very popular gynecologist and infertility specialist, Dr. Farzana Diba, as the moderator of today's program. Dr. Farzana Diba passed her MBBS from Dhaka Medical College in 2000 and completed her FCPS and MS in OBGYN in 2005 and 2012. Finally, she acquired her FCPS in reproductive endocrinology and infertility from BCPS in 2017. She has more than 20 publications on infertility. Currently, she is working as Associate Professor of Department of Reproductive Endocrinology and Infertility in Bangabandhu Sheikh Mujib Medical University. Now I want to move on to Dr. Farzana Diba, Madam, to conduct the webinar. Madam, please.
Distinguished guests, ladies and gentlemen, Assalamu alaikum. It is my privilege and honor to invite you in this exclusive webinar on PCOS. PCOS is a serious genetic and hormonal metabolic reproductive disorder which is affecting 8 to 13% of reproductive aged women and girls. It is the leading cause of female infertility and the prevalence of other serious health hazards including obesity, type 2 diabetes, cardiovascular disease and endometrial carcinoma, depression and many more. So September is the PCO awareness month to help spread the word PCOS, a condition that according to the World Health Organization impact over 100 million of women worldwide. This month is dedicated to raising awareness, educating public and conquering PCOS by sharing personal stories. The aim of this awareness month is to improve and disseminate information regarding diagnosis and treatment of the disorder, improve quality of life and outcomes for many women and girls with PCOS, promote the need for further research, improve treatment and care option, and to acknowledge the struggle affecting the all women, the girls afflicted with PCO, urge medical research and healthcare professionals to advance their understanding in order to research, diagnosis, and provide assistance, and to encourage countries, states, territories, and localities to make PCOS a public health priorities. With this view in mind, today's seminar has been arranged. So distinguished guests, ladies and gentlemen, I am inviting you to this exclusive PCO awareness program. I am happy to announce our national professor, Professor Shahla Khatun is with us, and we are welcoming Madam to this exclusive seminar. Madam, welcome you to this seminar. Today's webinar will be divided into 2 sessions. In the first session, 4 eminent speakers of home and abroad will speak on different aspects of PCOS and PCO-related infertility. After that, there will be an interactive panel discussion. Our first speaker will be Dr. Shakila Ishraq, Associate Professor, Department of Reproductive Endocrinology and Infertility. She will speak on PCOS challenge in diagnosis. Dr. Shakila Ishraq.
Thank you, Farzana.
Dr. Shakila Ishrat is currently working as the Associate Professor of the Department of Reproductive Endocrinology and Infertility of Bangabandhu Sheikh Mujib Medical University. She earned her MBBS degree from Dhaka Medical College in 1993. Then she acquired her FCPS and MS in obstetric and gynecology. And she got advanced infertility and IVF training from All India Institute of Medical Science. She is the speaker of different national and international conferences. She has more than 20 publications on infertility. She is the lifetime member of BCPH, OGSB, Fertility and Sterility Society of Bangladesh, and Laparoscopy Society of Bangladesh. The diagnosis of PCO is always a mystery. PCO is the leading cause of female infertility worldwide. However, due to heterogeneity of the disorder, the criteria for diagnosis remains subject of conjuncture. So, may I now request Dr. Shakila Ishrat to present on PCOS challenge in diagnosis. Dr. Shakila Ishrat. Dr. Shakila Ishrat, ma'am, may I request you to share your slide on the screen? Dr. Shakila Ishrat. Dr. Shakila Ishrat, can you hear me? Dr. Shakila Ishrat. Problem most probably. Dr. Shakila Ishrat.
Hello.
Yes, madam, we can hear you. You can share your slide now. You can share your slide now. Now I am requesting Dr. Shakila Ishrat to sharing her slide.
Well, this September is PCOS Awareness Month. Teal color, a blue-green color.
Madam, you have to share your slide first. You have to share your slide.
Okay.
Slide দেখা যাচ্ছে না না
দেখা যাচ্ছে না
না নিচে শেয়ার স্ক্রিন যে গ্রিন অপশনটা আছে ওখানে টিপ দেন আপা
এটা দিয়েছি তো
স্লাইডটাকে মিনিমাইজ করে রাখছেন আপনি ওপেন করে
মিনিমাইজ করে কিন্তু এখানে প্রবলেম যেটা হচ্ছে এখন পারা যাচ্ছে
এখন হ্যাঁ এখন আসছে হ্যাঁ হয়েছে এখন আপনি ইয়াটা করেন ওপেন করেন হ্যাঁ ঠিক আছে এখন ম্যাক্সিমাইজ করেন হ্যাঁ হয়েছে আপা স্টার্ট করেন
PCOS Awareness Month. This September is PCOS Awareness Month. The color is teal, a blue-green color awareness ribbon. It supports polycystic ovary syndrome. So next 15 minutes, we will be with these colored slides. Polycystic ovary syndrome. There is no universally accepted definition. The common definition or criteria which we hear of, the Rotterdam criteria, they are more suitable for selecting population for studies rather than clinical diagnosis. The traditional picture is obese, hirsute women walking in with menstrual problems, but the diagnostic dilemma is not all obese, hirsute women with menstrual problems are PCOS, and not all PCOS women are obese, hirsute, or have menstrual problems. Now let's start with symptoms and signs. The most common symptoms are ovulatory dysfunction resulting in menstrual dysfunction and or infertility, Menstrual dysfunction occurs in 60 to 85% of women. It includes oligomenorrhea, that is less than 8 cycles per year, amenorrhea, polymenorrhea, that is regular cycles with less than 21 days. Polymenorrhea is very uncommon in PCOS women. It occurs in less than 22% PCOS women. And all these menstrual dysfunctions are occasionally accompanied by the anovulatory bleeding in the form of irregular or prolonged bleeding. And what is interesting is that in 15 to 20% of women, the menstruation is regular. That is, there is eumenorrhea. In that case, ovulatory dysfunction can be assessed by absence of premenstrual molemina only. Next common symptoms are clinical hyperandrogenism, manifested as hirsutism, acne, and androgenic alopecia. Hirsutism is abnormal growth of male pattern hair on the face and body of women, and it is a very distressing symptom. Acne results from the androgenic effect on sebaceous gland, androgenic stimulation of sebaceous gland. Androgenic alopecia, it means female pattern hair loss, which is more apparent on caput, but in severe cases, it may involve the frontal or bitemporal hairline. Hirsutism has gradual onset over months to years, usually after puberty. It is usually assessed by modified Ferriman-Galloway score, and the score, when it is more than 6 or 8, it indicates hirsutism. But clinically, the response is better judged by the method and frequency of hair removal procedures. The exception are mongoloid races. They usually do not present with hirsutism. So there is ethnic variation in hirsutism. It is more common in South Asian compared to other Asian people, and it is more common in South Asian women and Mediterranean women compared to white Europeans. Also within the same race, there is varying sensitivity of hair follicles to androgen. So this means with the same androgen levels, some women will present with androgenic features like hirsutism or acne, others will not. Next, obesity. 30 to 65% of women with PCOS are obese. That is, it is a common but not essential feature of PCOS. PCOS relates more to genetic and environmental factors. And in obesity, there is hypothalamic pituitary dysfunction. There is decreased secretion of sex hormone binding globulin from the liver, and this results in increased level of free testosterone. So obesity by itself leads to a PCOS-like hyperandrogenic features. And it is assumed that obesity introduces the risks of developing PCOS. In addition, it aggravates the insulin resistance and compensatory hyperinsulinemia in the women who already have PCOS. Now, whether BMI or waist circumference. Obesity is distributed centrally in PCOS. In PCOS, insulin resistance is the problem. Insulin resistance is more related to intra-abdominal fat, intraperitoneal or visceral fat than subcutaneous fat. That is why lean women with PCOS have a higher waist to hip ratios compared to the normal women matched for BMI. Therefore, we think now that waist circumference is a better tool, an easier tool than BMI to assess, counsel, and manage patients regarding their weight management. Now, what are the cutoff values for BMI in South Asian women? They are not the same as European women. The normal is 18 to 22.9, overweight is 23 to 24.9, and obesity is 25 or above. Cutoff values of waist circumference in South Asian women is 80 centimeter. These are because the South Asian women are more insulin resistant than their European counterparts of same BMI, same waist circumference. Now acanthosis nigricans. This is skin change typical of insulin resistance. dermal hyperkeratosis and papillomatosis. It is apparent as gray or brown, velvety, or sometimes verrucous hyperpigmentation on the neck, on the vulva, groin, axilla, and submammary areas of women. It is usually absent in lean women, but increases in obesity. But the dilemma is that all obese women have acanthosis nigricans. So in most cases, diagnosis can be made on history and physical examination. But it is also true that in others, the diagnosis is suspected but cannot always be defined. So I have to go for investigations. The first investigation is pelvic ultrasound, focusing on polycystic appearing ovaries and endometrial thickness. Polycystic ovaries result from chronic anevolution. What we find? We have many follicles peripherally displaced by a central echogenic area. This is also present in 1/3 of normal fragile women who have normal gonadotropins and normal estrogen level. And they're also present in 14% of women having this OCP. This is probably because there is an evolution due to hypergonadotropic hypergonadism. So there is confusion. There is multiple cysts scattered in the stroma, but in case of polycystic ovarian syndrome, we should focus on this area, the echogenic area. More and more cyst cell follicles become saturated, and the thicker tissues they add to the stroma. And according to the criteria, Rotterdam criteria, this number of follicles 2 to 9 millimeters, which are visible on sonogram, these should be at least 12. And according to Androgen Access PCOS Society criteria, it should be at least 25. But the difficulty is it needs a sonogram of very high resolution, which is not always present in our settings. So we have to depend on some hypertrophic follicles surrounding a thick echogenic area. Next, endometrial thickness. Because of anovulation, the endometrium continues to grow, and without ovulation. So there is thick echogenic endometrium with hyperplasia in 36% cases and atypia in 9% cases. However, this thickness depends on hormonal manipulation. So you have to remember that. After prolonged administration of progesterone to the thin or during heavy bleeding, this may not be this way. But the usual is thick echogenic endometrium. Next, endocrine parameters. Hyperandrogenemia. There is elevated total and free testosterone. But what is important is free testosterone, because with the same total testosterone, there may be variable levels of free testosterone, and this is the active form of testosterone. Whenever there is decreased secretion of sex hormone binding globulin, there is increased free testosterone, but measurement of free testosterone is very difficult. It is impractical in clinical settings. Next, elevated dihydroepiandrosterone sulfate. It is an adrenal hormone, and whenever there is elevated DHEAS, there is elevated estrogen. So there is little utility in defining PCOS in mild hyperandrogenemia. And what is more important is whenever there is clinical hyperandrogenism, that is whenever there is hirsutism, whenever there is acne, it is apparent that there are increased testosterone, both total and free. So doing testosterone is not always that important. It can be done whenever there is confusion, that it appears to be a PCOS, but there no obvious hirsutism or no obvious acne. High LH-FSH ratio. It is not a reliable diagnostic criteria because they neither make nor exclude the diagnosis of PCOS. Altered LH-FSH ratios are more often encountered in lean than in obese women with PCOS. Confusion arises when a PCOS woman receives a long period of progesterone and then LH is done following withdrawal of bleeding, and LH is low. So there is confusion with hypogonadotropic hypogonadism. In that case, we do estrogen. Also, there are occasionally some women who presents with polycystic ovary, oligomenorrhea, but no hirsutism. And when we do gonadotropin, she's either eugonadotropic or hypogonadotropic. And in that case, we go for another endocrine parameter, and that is AMH. Anti-mullerian hormone significantly is higher in PCOS. AMH level more than 4 nanogram milliliter is suggestive of PCOS. And in PCOS, we get AMH as high as more than 10, more than 20, like that. And what this AMH comes from the many primary preantral and antral follicles that is usual in PCOS. It is secreted by the granulosa cells. Now, metabolic parameters. Insulin resistance is prevalent in 30 to 35%, and is greater in the obese than in lean PCOS. It is assessed by fasting serum insulin concentration, fasting glucose insulin ratio, homeostatic model assessment of insulin resistance of HOMA-IR, and also by OGTT. IGT is in 35% of PCOS and altis mellitus in 10%. Fasting serum insulin concentration, when it is more than 20 to 30 in glycemic white European women, it suggests insulin resistance. But the level is much lower in case of our population, South Asian women, it is around 10 milliunit per ml. Fasting glucose insulin ratio less than 4.5 is sensitive and specific of insulin resistance. And HOMA-IR, the cutoff value in our population is also around 2. Dyslipidemia, it is relatively common. Nearly 70% have at least one borderline or elevated lipid level. Decreased HDL and increased triglyceride. These two are related to insulin resistance, but increased LDL is not. It is more maybe related to hyperandrogenemia or other factors. There is difficulty in diagnosis of PCOS in adolescents. Adolescents without PCOS have relative hyperandrogenemia, insulin resistance, physiologic anovulation, and cystic ovaries. Since they have cystic ovaries, so diagnosis of PCOS in adolescents rests on ovulatory dysfunction and on hyperandrogenism. It doesn't depend on cystic ovaries. Ovulatory dysfunction in adolescents is apparent by consecutive menstrual intervals more than 90 days, even in first year after menarche, menstrual intervals persistently less than 21 or more than 45 days, 2 or more years after menarche, and lack of menses for 15 years or 2 to 3 years after this budding. Now, the revised 2003 Rotterdam criteria adopted by SRN and ESHRE Joint Consensus Workshop, 2 out of 3 diagnostic criteria is needed for diagnosis: oligoanovulation, clinical and or biochemical hyperandrogenism, polycystic ovaries and or increased ovarian volume in either ovary. Androgen excess in PCOS society criteria is hyperandrogenism, clinical and or biochemical, ovarian dysfunction evident in oligoanovulation and or polycystic ovaries, and there must be exclusion of related disorders like non-classic congenital adrenal hyperplasia, hyperprolactinemia, Cushing syndrome, and androgen secreting tumors. Thyroid stimulating hormone is done to exclude thyroid dysfunction in all anovulatory women. Prolactin should be done to exclude high prevalence of hyperprolactinemia among women with menstrual dysfunction. It is said that prolactinemia and hypothyroidism is associated with PCOS, but actually it is differential diagnosis. Mild increase in prolactin or TSH level sometimes found in women with PCOS, and that is more related to ovulatory dysfunction. There is often confusion with non-classical congenital adrenal hyperplasia. A specific testing like 17-alpha hydroxyprogesterone should be reserved for early onset of severe hirsutism in pre or perimenarcheal, in family history when there is high risk ethnic growth. So the take-home message are different clinical presentation in different ethnicities in different persons. PCOS is a functional derangement, difficult to define clinically. Different endocrinopathies like hyperandrogenemia, hyperinsulinemia, and high LH leads to persistent anovulation and emergence of polycystic ovaries. Thank you.
Thank you, Dr. Shakila Ishrat, Madam, for your excellent presentation. The management of PCO is not determinist and surrounded by many controversies. Nowadays, use of adjuvant in PCOS has drawn interest to the researcher as many studies showed a positive effect of adjuvant on hormone profile and fertility outcome of PCOS patient. Our next speaker is Dr. Kokila. She will speak on adjuvant in PCOS. Distinguished guests and ladies and gentlemen, if you have any queries or anything to share, you can put it in the chat box so that we can discuss this if we have time later on. Dr. Kokila Das, she is the fertility consultant of Care Fertility, Bhubaneswar, Odisha State, India. Consultant intrauterine surgery, Spars Hospital, Bhubaneswar. Clinical IVF and fetal medicine trainer, Embryo Edu internationally. Special interest on mini IVF, fetal echo. Invited speaker and faculty in several national and international conference, workshop, hands-on training, and webinar. Conducted several international workshops on clinical IVF, embryology, hysteroscopy, and fetal medicine. She is the co-editor of JOFI, MOFI, NIFS, and newsletter. Founder member, OFS, Neo India Fertility Society, founder member, World Hysteroscopy Forum, and she is also the founder member of Asia Oceanian Fertility Research Forum and member of AOFRF, ISAR, and IMA. Now, may I request Dr. Kokila Das to share her slide and present on adjuvant of PCO, use of adjuvant on PCO.
Thank you so much, Dr. Farzana, for your kind introduction. I hope you can hear me loud and clear.
Yes, we can hear you, but you have to share your slide now.
Yes, so I'll be sharing my slide now. At the outset, I would like to thank the organizers, those who have invited me as a speaker to this informative webinar. A special thanks to Dr. Jasmine Banu, Professor, Reproductive Endocrinology and Infertility, Chairman also. And it's a pleasure to be here. And I bring greetings from Care Fertility India to my near and dear ones of Bangladesh. So now I start sharing my screen. Can you see my screen? Can anybody tell me?
Yes, we can see your skin on adjuvant in PCOS.
Yes, just give me a moment. Just give me a moment. Can I start the presentation?
Yes, please, ma'am.
Yes. Today, I'm going to talk about advancing PCOS, which is a most controversial and conflicting topic in the treatment of PCOS. So first, let us know why adjuvants or supplements are needed in PCOS. It is adjuvants are nothing but add-ons which improve or enhance or optimize the results. So it also helps us to improve the bloods, for example, in PCOS, in terms of insulin, cholesterol, and triglycerides. It also helps in improving ovulation and equality. So it also replaces nutrients that are missing in your diet due to malabsorption, and it optimizes the nutrient levels. Apart from inducing ovulation and improving fertility rates, it also has been used in to prevent long-term complications, because some of the common PCO managements are not controlled, cannot control all the symptoms of PCOS, and it also normal treatment in PCOS will not prevent long-term complications and other psychological disorders also. So as my previous speaker has spoken about the clinical signs and symptoms, there is around incidences around of insulin resistance is seen in about up to 70%, especially in obese women. That's why 70% is a large number, and we need to address the issue of insulin resistance. Basically, the pathophysiology in PCOS is more of insulin resistance. That's why there is a huge discussion on the insulin sensitizers, whether it could be metformins, bioglitazines, and others, which I'm going to talk about in another 15-20 minutes. First, let me talk about insulin sensitizing agents. We all know that metformin belongs to begonite groups, and thiazolidiners, which are called TZDs, pioglitazone and rosiglitazone, ionositols in the form of myoinositol and dechloroinositol, and N-acetylcysteine. So coming, the first thing we'll be talking about is insulin sensitizers, which most commonly used and widely researched are metformin. We know that clomiphene therapy has a valuable success rates in anovulate women if properly stimulated and proper follicular monitoring is done. However, it is lowest in the women with PCOS with insulin resistance. Currently, there is increasing evidence of ISDs which are effective in PCOS. However, we know that not all cases respond to insulin sensitizers. So, exploring other mechanisms to induce or augment ovulation in CC-resistant patients is a desirable goal, especially in the reproductive medicine. Clomiphene citrate failure is frequently encountered in PCOS, and insulin resistance is the cause of failure in patients with PCOS mostly. We not only see in obese patients, but it is also seen in thin and lean patients also. Hyperinsulinemia influences ovarian and adrenal steroidogenesis as well. Consequently, ISDs were proved to be effective in treating PCOS. You see around 15 to 20% of the PCOS are clomiphene resistance when we use clomiphene citrate in the dose of 150 milligrams over a period of 5 days for up to 2 to 3 cycles. So considering the high prevalence of insulin resistance and hyperinsulinemia as the most common etiological factors, many attentions were drawn on ISDs. So coming to the rationale of the use of metformin in PCOS patients, this is a beautiful picture showing the pathophysiology of PCOS. Here we can see that there is a decreased insulin receptor binding, post-binding receptor abnormalities on environmental factors and genetic factors put together. Insulin resistance takes place and it leads to compensatory hyperinsulinemia. So compensatory hyperinsulinemia has a central mechanism and a peripheral mechanism. If you can see in the picture clearly, the central mechanism, what happens is there is abnormal LH pulsatility, due to which most of the times we see there is an LH rise compared to the FSH. Coming to the compensatory mechanisms, in the liver, there is increased glucose production. In the ovaries and adrenals, there is ovarian and adrenal steroidogenesis taking place. So coming to metformin, in fact, it is the most extensively and widely studied ISDs in the treatment of long-term and short-term sequelae related to PCOS. So it's also used as a preventive treatment in girls at a high risk for PCOS development. insulin resistance with compensatory hyperinsulinemia is a probably cornerstone of the pathogenesis of PCOS, for which we are going to talk about more about sensitizers now. So when you enter into the Google or search anywhere about insulin resistance and insulin sensitizers, especially in PCOS patients, you will find a plenty of information about insulin sensitizers. First thing which pops up on your screen would be a metformin, and there's thiazolidines and pioglitazone, rosiglitazone, D-chiroinositol, and many more. So there are quite a few trials, as high as 91 trials and RCTs and meta-analyses, which have been increasing over the period of time from 1994 up till 2008. It is seen, but it is growing as a pandemic, and is going much beyond our imagination. So this is the potential mechanism of action of metformin. We know metformin is a category B drug according to FDA. So coming to the action of metformin, peripheral and central, as I described the pathophysiology. So it acts on the pathophysiology basically. In the central mechanism, it regulates the LH control, and in the liver, it decreases the gluconeogenesis, and decreases the glucose absorption, and in the skeletal muscle, it increases the uptake of glucose, and on the adipose tissues, it increases the glucose uptake, thereby increasing the insulin sensitivity and decreasing hyperinsulinemia. And that's how you are preventing the long-term complications on the adrenals by decreasing the androgen production, and long-term complication of the endometrium, and preventing the endometrial carcinoma in future, and then on the ovary to decrease androgen production, and indirectly decreasing the free androgens and increasing the SHBG, androgen production, which is one of the most commonest presentation in the adolescent group. So what are the effects of hyperinsulinemia? Basically, when there is increased insulin, it decreases the binding proteins and increases the unbound androgens. That's how you see hyperandrogenemia. And it reduces the good cholesterol, so-called the HDL, and increases the risk of PCOS along with insulin resistance around 50%, and type 2 diabetes around 8%, and other features like acanthosis nigricans. Reduces hepatic glucose production and intestinal absorption, as I said, and increases SHBG and decreases the androgens. So metformin is a category B drug, which is available as immediate acting or sustained release. So normal side effects being nausea, vomiting, and diarrhea, which commonly the patient can complain of. So when you start using metformin, it has to be started at the lower dose, around 500 milligram, slowly and steadily for about a week, and then gradually increase up to the requirement if the patient is compliant to the drug up to 2 grams. But the one important thing what is to be kept in mind is about the risk of metformin when used for long term. There are hepatotoxic and renal toxic effects. Rarely it is been seen that it causes lactic acidosis when used for prolonged years of more than 3 years. Coming to TZDs, it was a treatment of choice for metabolic diseases basically. So the class of drugs are glitazones, which are rosiglitazone and pioglitazone. They are category C drugs. So this was the first, triglitazone was the first drug which was studied, but it was withdrawn from the market due to hepatotoxicity. Only very few recent studies are there regarding rosiglitazone and pioglitazone because of their long-term cardiovascular risk associated with it. So it is not widely used, not only for that reason, it's also because if the patient is planning for conception and if they conceive you while on this TZC, because it is category C drug, it may be teratogenic to the fetus. So coming to metformin as the first step for ovulation, yes. So now I'm going to talk about metformin with some scientific proof behind, which some studies may agree and some meta-analysis may not agree. So coming to the largest study, Allegro et al. Said in the meta-analysis that efficacy of metformin, CC, or both the drugs in therapy in PCOS patients demonstrated no significant clinical benefit from metformin administration over CC as first-line therapy for ovulation induction. That means metformin alone cannot be used as an independent drug for ovulation induction because it is not an ovulation-inducing drug. Probably it is just another adding adjuvant to it. So clomiphene citrate remains the first choice of ovulation induction, and metformin cannot be the first choice for ovulation induction. How about metformin with CC as co-treatment? As I said, so meta-analysis design studied said that in CC resistant patients, they did say that Metformin along with CC significantly had a better effect than CC alone. Then, CC-resistant PCOS patients may be given a benefit of trial before doing a drill. So there was a large study by Legro et al. Regarding its association with infertility, where RCT was done for 6 months, and without screening them for insulin resistance, they were directly put on CC and metformin. So there was a large number, as good as 626 patients, which were taken into consideration. And there a group of people were put on only CC with placebo, another group on only metformin and placebo, and another group on both CC and metformin put together. You can see a number of, there was a gross increase of live birth and ovulation rate as high as 26.8% of live birth rate and ovulation of as high as 46%, where you can see it is grossly more compared to CC alone or metformin alone. So now the main question is how long the metformin should be used. So because length of metformin administration became a major concern because of its side effects. So initially wondering whether to give it for a short course or a long course. According to the studies and the books, they say that long course is as high as 3 years and short course is less than 4 weeks. So short course, when it was used for less than 4 weeks, it found to be very suboptimal and it could not assess the exact benefits of it. The short term was really short and long term of more than 3 years is really long. So, and unfortunately also we do not have many RCTs regarding the short course or the long course, and there is insufficient data to determine the efficacy of long and short courses. And in a study of fertility study quoted that effect of short-term and long-term metformin treatment on menstrual cyclicity in women with polycystic ovarian syndrome, when it used for 6 months, it did have a beneficial effect. So we consider that metformin can be treated as up to 6 months safely, and beyond which, when you consider treating for a long term, you need to be monitoring the hepatic and the renal status. How about using metformin with rosiglitazone? No significant benefit of rosiglitazone addition was detected. It suggests that the use of metformin with rosiglitazone association is not presently supported by clinical evidence. Further studies are needed given the selection basis of enrolled population. Metformin for hyperallergenic symptoms in women with PCOS. So would you like to use metformin as a first drug of choice for hyperallergenic symptoms? Well, metformin was found to be less effective than OC pills in when studied while in reducing the serum androgen and testosterone levels. So metformin was less effective than OCP even in improving the menstrual pattern. So that's how metformin cannot be used as a first line of drug for hyperandrogenism and also to correct the menstrual irregularities. Rather, OCPs are a better choice. How about using them in ICSI and IVF cycles? Pre-treatment with metformin was not suggested in all cycles, but in high responders like PCOS, it was significantly found that the amount of gonadotropin consumed during stimulation was reduced, and it also reduces the OHSS risk. How about using metformin for long-term health maintenance in women with PCOS? Because we know that long-term complications are cardiovascular symptoms and associated with endometrial cancer and diabetes. There were insufficient data regarding the use of only metformin to prevent long-term complications. Nonetheless, if metformin restores cyclicity and ovulation, we know that indirectly it is giving a protective effect by preventing endometrial cancer, because in PCOS there is unopposed estrogen which is acting on the uterus and for prolonged period of anovulation causing increase in the endometrial thickness, indirectly leading to endometrial cancer. Well, if it is added as an adjuvant, it can restore the cyclicity in ovulation, thereby preventing the endometrial cancer. And a role in improving long-term health outcomes are still debatable. So once the patient is conceived after a treatment with PCOS, the question comes is whether the patient will continue metformin or not, and what is its association with the pregnancy loss. So there are around 30 to 40% of people having miscarriage in the PCO group. So there were some encouraging data from the retrospective and prospective trials saying that it did prevent the early pregnancy losses and it did have a beneficial effect. PCOS with obesity, there were high rates of miscarriages. So that's how this Legro et al. Supports the use. and observation studies also showed that it reduces the risk of miscarriages. And one meta-analysis said that metformin had no beneficial effects. So metformin itself is full of controversy because every year, every now and then, the data keeps changing. Finally, it is for the treating physician to assess the benefit versus the risk and to continue with metformin. How about gestational diabetes? In a combined prospective and retrospective studies, it was shown that there was a gross reduction of GDM, 20% in patients who were PCOS in comparison to pregnancies who were not on metformin. It was another prospective study by Glucek et al. Also showed that PCOS subjects' metformin use was associated with 10-fold reduction in GDM. Now, how about using the combination of metformin and insulin, especially in GDM? So there was a big MIG trial where 751 pregnant women were taken into consideration between the period of gestation of 20 and 33 weeks. And in this randomized study, metformin and insulin were supplemented together so that the trial confirmed that metformin alone or in combination with insulin is as safe as insulin alone in patients, demonstrating a higher satisfaction rate in the metformin treatment. That means metformin either alone or in combination with insulin did have some beneficial effect in preventing the complications of GDM. How about the neonatal outcome? So the metformin, it was administered for the first 12 weeks of pregnancy. It not only decreased the incidence of small or large gestational age, but also lowered the risk of neonatal hypoglycemia. So there was no significant difference in incidence of neonatal malformations, which we all obstetricians are worried about. And several authors and all available studies were in agreement with this. And few meta-analysis also showed there is no increased risk of major malformations when metformin is administered during the first trimester of pregnancy. So there are some controversies. So we all believe in RCOG, Cochrane, and ASRM, right? So I have noted down some of the controversies or their evidence-based studies. What RCOG 2008 said that metformin alone or with CC showed no benefit in ovulation induction in PCOS treatment for the management of infertility. And Cochrane 2012 also said ISDs either alone or in combination to induce ovulation did not increase the chance of having a live birth. In annullatory cycles, according to ASRM and ESHRE, there was no benefit in fertility or live birth rates. Use was not recommended as like level A evidence. So there was no effect on miscarriage risk when given before pregnancy. There was no effect on decreasing pregnancy complication or fetal weight. Clinical practice guidelines from Endocrine Society 2013 says metformin can be used for PCOS along with type 2 diabetes and impaired GTD, and those who fail to respond for lifestyle modification. It can be used as a second line for menstrual irregularity for those who do not tolerate hormonal contraceptives, and it can be used as adjuvant for the prevention of OHSAs in females with PCOS who are undergoing IVF. Cochrane 2014 said metformin before or during IVF increasing clinical pregnancy rate and decrease in OHSAs, but it doesn't increase the live birth rate. Coming to Indian PCOS Society 2015, let us see some points here. Metformin is not recommended as first-line therapy for the management of menstrual irregularity alone. Due to limited evidence on the use of metformin in adolescents with established glucose intolerance, it is recommended against its use in adolescent PCOS. That means in adolescent PCOS, it does not have any role unless they have an impaired IGT. Lifestyle modification exercise should always be the first choice, and it is better than metformin in improving hyperandrogenism, obesity, and signs of IR. Therefore, recommends lifestyle modification as the first line of therapy, followed by metformin even in adolescent and children. Metformin should be initiated in children only after waiting period of more than 2 years after post-menarche. In women with PCOS, it is recommended not to use metformin therapy only during pregnancy until specific evidence on beneficial effect is demonstrated, grade B evidence. Due to insufficient evidence, alternative therapies like acupuncture, other therapeutic agents are not recommended in the management of hyperandrogenism. So there are a lot more confusions regarding the use of adjuvants, especially metformin. So some conclusions on metformin finally is that it's not the first choice for induction, as I said earlier. It has been seen that there was a decreased incidence in early pregnancy losses, so it can be used wisely. Metformin has no advantage in newly diagnosed PCOS. Although uncontrolled trials reports are available, metformin is found to be safe during pregnancy. Metformin treatment during pregnancy may be protective against complications. Legro et al. Also said that it is prudent to discontinue metformin when pregnancy is confirmed. But as I said, it is decision lies with the treating physician to evaluate the risk and benefits and the counseling of the patient where the patient is willing to take the drugs after understanding the pros and cons. What are the potential predictors who can say that whether metformin is beneficial or not, whether metformin is going to act on somebody? So these are the potential predictors used are body weight, insulin sensitivity, hyperandrogenism, waist-to-hip ratio, and genetic factors. So why potential factors are important for us? Because the beneficial effect may vary according to the clinical characteristics. And we know there is a complexity in diagnosis of PCOS because of its phenotypes. And the knowledge of predictors for metformin response is very crucial. It also helps us to individualize or tailor the treatment to improve the metformin efficacy and optimize the safety profile. Coming to the body weight, according to the study, said that irrespective of the patient, whether lean, overweight, or obese, it was observed that all the three groups, they demonstrated a significant decrease in the fasting insulin levels when it was used for 6 months. So it was found to be beneficial, and it can be used in any of the group provided there is an insulin resistance is proven. And hyperandrogenism, yes, it was found to be of great improvement in biochemical tests in terms of decreasing the androsterons and the testosterons. Genetic factors play an important role because we know PCOD is has severe genetic polymorphism, and it is strongly related to the genetics. So it does play a role in response. Coming to the insulin sensitivity, insulin resistance has to be established. So only those patients who are resistant would substantially benefit from the improved insulin sensitivity when induced by metformin. Coming to the role of statins now. So what do statins do? They reduce androgen levels, they decrease the ovarian size, and then improve the cyclicity. But can they be used as a first line or an adjuvant? Yes, it can be used as an adjuvant, but more trials are needed. It is found to be beneficial in morbid obese patients because it's a PCOD phenotype variant where they are morbidly obese and they're not responding. And both orlistat and sibutramine, they block the intestinal absorption of fat independent effect, and they have an independent effect on androgen insulin resistance. Sibutramine is out of the market now, and orlistat is the one which has been regularly used in terms of obesity or morbidly obesity, where we give them 60 milligram to 120 milligram after a major meal. So currently, it is not the first line of therapy for obesity in women with PCOS, so it can be added as an adjuvant. So you can see a spectrum of adjuvants here from ionositols, magnesium, vitamin D, NAC, zinc, melatonin, B12, you name any, there are plenty. So I have got a few of them here in the picture. Myonisitol and D-Chiro. So there was a result from the International Consensus Conference that myonisitol and D-Chiro were used, that it did prevent GDM when it was used at a dose of 2 grams twice daily, and when they're used in the ratio of 40:1. Basically, they act as a second messenger of insulin. Myo-IPGs mediate glucose uptake at cellular level. DCI mediate glycogen synthesis, and it's an important constituent of the follicle microenvironment. It plays a key role in the nuclear and cytoplasmic oocyte development. So high concentration of myonisitol in human follicular fluid provide a good marker of good quality of oocytes. So potential benefits of inositol in a nutshell. So you can see a lot of benefits here, like regulating the menstrual cycle, improving the egg quality, decreasing the testosterone, lowering the sugars, lowering the cholesterol, and many more benefits. Coming to NAC, it is a multipurpose antioxidant study. Basically, NAC is a derivative of amino acid L-cysteine. It's a precursor of glutathione. Basically, what it does is it facilitates safe detoxification. It is an antioxidant. It de-stresses, and it is found to be hepatoprotective, mucolytic, neuroprotective effects, and also as a fertility enhancer when it is used in the dosage of 1.6 to 3 gram per day. A lot of randomized trials, about 8 to 10, saying that a large group of 910 PCOS women were taken into study, and they all showed an improvement in BMI, total testosterone, insulin, and lipid levels. So NAC had significant improvement in pregnancy and ovulation rate as compared to placebo. So NAC showed similar benefits to metformin for improving pregnancy rate, spontaneous ovulation, menstrual regularity, insulin resistance, and cholesterol. What about its role in ICSI? NAC has shown that it improves the oocyte and the embryo quality in PCOD patients, especially when doing an ICSI. It decreases the insulin and LH levels if it is given as a pre-treatment before doing an ICSI for about 6 weeks. So coming to combination therapy, there's a study here showing the efficacy of inositol, antioxidants, vitamins in obese and non-obese patients when they were given for 12 weeks. So there was found to be an improvement in menstrual cyclicity, improvement in acne and hirsutism, both in obese and lean PCO patients. There was a significant reduction in the body weight and BMI, so it may be a fruitful approach in PCOS. I just spoke about metformin regarding its duration of usage, like short-term or long-term. When metformin is used for a long term for more than 6 months, it was found that the patients were deficient of vitamin B12. So it makes some sense using vitamin B12 when the patient is on metformin for a prolonged period of time to prevent vitamin B12 deficiency. Now, we've been hearing about vitamin D, so it has become a part of prescription of late. So why should we prescribe vitamin D as an adjuvant? It was found that in PCOD patients, there were low levels of vitamin D, and low levels of vitamin D were associated with obesity and insulin resistance, hyperandrogenemia and dyslipidemia, and the risk of diabetes and CVD. And it was found that supplementation of vitamin D did lower the serum AMH levels, and clinical trials also show some improvement. So there is some meaning, or there is enough data to support it. But still then, one believes that double-blind studies are still required to make it a part of regular prescription. Coming to vitamin E and C, it was found that in PCO patients, it was decreased significantly. So it becomes a part of adjuvant while treating PCO. Coenzyme Q10, you must have seen in tablets or in particular as a component, which is and you particularly used in energy production uses. It seemed shown to improve egg quality and ovulation. Also helps in migraines. It helps to lower the cholesterol and the insulin levels. Can be used in a therapeutic dose of 200 to 600 milligram. So ubiquinol is a form where it is best used and absorbed. Another antioxidant is resveratrol. It is found in grapes, red wines, and peanuts, which is an anti-aging, anti-cancer, and cardioprotective. Study group also showed that it did have some benefit in reducing testosterone and reducing DHEA sulfate and dropping the fasting insulin by 32%. So there are a lot of supplements available for PCOS like cinnamon, chromium, lipoic acid, melatonin, and all forms of vegetables, whatever you name, whatever you can see in the picture. So in conclusion, when we talk about supplements, we know that its use is common in PCO population. Adjuvants added to healthy diet and lifestyle can offer health benefits and aid in improving the ovulation. Women with PCOS may be at risk or having a deficiency in certain nutrients, and PCOS is a heterogeneous of different phenotypes, and more RCTs are needed to determine the benefit of supplement use in different women with different PCOS. So women with PCOS should discuss the health benefits, risk of supplement use, and their appropriate dosage, and should be monitored by healthcare professional. And several complementary and alternative therapies have been recently added as an adjuvant, like lifestyle modification, acupuncture, yoga, aromatherapy, and then many more in the picture. You can see there, CAM. They have been considering it as an adjuvant. So that's why when you go look for supplements, especially for the general public, you should know what you're looking for. because you find a lot of data, but you should also have a scientific evidence. So you cannot just go and pick up some supplements from the shop or outside anywhere without seeking help. So it's better that general public should be aware that they should seek some medical help, because they can guide you better with some scientific evidence, so that it will prevent you from having detrimental effects on your lifestyle. It's not only to prevent complications, and it is not only for the people who are planning to conceive or for having a reproductive disorder. It is also important to prevent the course of the disease by preventing the long-term complications and their consequences because of its association with mortality and morbidity. So prevention is always better than cure. As Benjamin Franklin said, an ounce of prevention is worth a pound of cure. So PCOS has become a pandemic. It is on the rise, just like coronavirus. We are living with it, and we are going to live with it for a few more generations. So as a healthcare worker, it becomes a responsibility to prevent this pandemic by utilizing the preventive strategies. And September being the month of PCOS awareness, it is a duty of our duty or as an health worker to counsel your patient and to advise them regarding the preventive strategies, so that we can end this pandemic for upcoming next generations. Thank you so much for your patience hearing. Over to you, Dr. Farzana.
Thank you, madam, for your outstanding detail on adjuvant in PCOS. Our next speaker is Professor Jasmine Banu. We know polycystic ovarian syndrome is a rather mysterious endocrine abnormality. It affects female reproductive performance as well as it has effect on female health. The endocrine and metabolic abnormality associated with PCOS lead to infertility as well as long-term health hazard. So Dr. Jasmine Banu, who is the main organizer of this session, she will speak on impact on PCOS on fertility, how to overcome, and recent advance. Professor Dr. Jasmine Banu is the chairman of the Department of Reproductive Endocrinology and Infertility of Bangabandhu Sheikh Mujib Medical University. Dr. Jasmine Banu has passed MBBS from Shere-Bangla Medical College Hospital, Borishal. She attained her MS degree from Bangabandhu Sheikh Mujib Medical University. She has published a lot of national and international journals, more than 30. She has done many research work. One research work has been published as book in Lambert University, Germany. She has got training in advanced laparoscopic training from Sunrise Hospital, Kerala, India. She got training in advanced trained in ART for Milan Hospital, Bangalore. She is the lifetime member of OGSV, Fertility and Sterility Society of Bangladesh, Laparoscopy Society of Bangladesh. Now, may I request Professor Jasmine Banu to speak on impact of PCOS on fertility, how to overcome recent advance. Professor Jasmine Banu.
Yes, thank you, our previous two speakers for their brilliant presentation, and I also thanks Dr. Farzana Diba for introducing me. And now I highlighted about the impact of the PCOS on fertility and how to overcome. We all know that the September is the PCOS month, even though there is no cure of the PCOS, but can help the patient by improving the education, by creating the awareness and providing the education, medical care, and by the supporting group. And why the rising the awareness? Awareness is needs because it is a complex disorder, genetic, hormonal, and metabolic disorder, and it also leads to the infertility, UV, and obesity, type 2 diabetes mellitus, cardiovascular disease, and endometrial cancer. So we prevent these things, making the life functional and the fertile. So this is needs through the awareness. Now the natural history of the PCOS, and the PCOS is starting from the fetal life when she is exposed with the maternal androgen and baby born with the lower neonatal weight. And when it is the passed through the adolescent, childbearing age, menopause and postmenopause. And also all these aspect is affected by the PCOS. When is affected on the adolescent, she presented with the premature adrenarche or premature precocious puberty. And when they go for from the childbearing age, she is associated presentation with the clinical hyperandrogenism, infertility, and irregular menstruation. And when is run through the menopause and premenopause, and they may presented with the diabetes mellitus, dyslipidemia, high blood pressure, and obesity. But when there is the postmenopausal age, she may presented with the cardiovascular disease and endometrial carcinoma and breast carcinoma also. Now, what are the factors leads to the PCOS? Several factors are responsible for the PCOS, and so first of for the oxidative stress, and then ongoing stress, hormonal imbalance, chronic inflammation, obesity, altered immune system, and genetic factor. All these factors are leading to the PCOS. And the oxidative stress and produces the PCOS. And there is some lifestyle change when the patient are obese, the undernutrition, or they're having the recreational drugs, cigarette smoking, alcohol, they are suffer from the oxidative stress. And due to these oxidative stress, they suffer the PCOS, endometriosis, preeclampsia, age-related infertility, or unexplained infertility. And now, how the oxidative stress produces the infertility. When there is oxidative stress and there is an imbalance between the pro-oxidant and antioxidant, and produce the large number of the reactive oxygen species. And these reactive oxygen are the superoxide dismutase, interleukin-1, and TNF-alpha. It is a pro-inflammatory marker for the oxidative stress. And these oxidative stress act on the granulosa cell of the follicle and also on the oocyte. And when it acts on the granulosa cell, it produces the luteal phase defect because the defect utilization and progesterone is production is the less, and there is a luteal phase defect. And when it acts on the desoxidative stress or ROS is act on the oocyte, and there is a decreased oocyte maturation and poor quality oocyte is formed. So there is indoor development as well. So also it is the fertilization defect. And the ongoing stressful condition is also responsible for the PCOS. This ongoing stressful condition, that is the stressful lifestyle, is there is an inadequate sleep and lack of physical activity. Both act on the hypothalamus to produce the increased formation of the cortisol level. And this increased cortisol causing the hormonal imbalance and insulin resistance, and thereby resulting the PCOS and the infertility. And now the factor is responsible for the PCOS, that is the chronic low-grade inflammation. And chronic low-grade inflammation is produced by the when the patient are intake of the large number of the vegetable oil, spicy food, or grilled foods, and that is the excessive amount of the sugar consumption. They produce the large number of the androgen, and there is a low grade of the inflammation. So low grade of the inflammation is usually by these drug, and so there is a excessive formation of the androgen. And another inflammatory, that is the adenokine, which is produced by the adipose tissue, and it causes the metabolic alteration and resulting the PCOS. And also the cytokine and the reactive oxygen species, it's produced by the liver, ovary, and other tissue, and also the creates the metabolic imbalance and the PCOS. Now the genetic factor, there are the several genetic factors responsible for the formation of the PCOS. There is an inactivating mutation of the LH hormone and inactivating mutation of the FSH receptor, or inactive mutation of the insulin receptor, and YP gene mutation. So inactive mutation of the LH receptor resulting the hyperandrogenemia. And when there is inactive mutation of the FSH receptor, and they produce the hypergonadotropic hypogonadism, but they are resistant to the gonadotropin and clomiphene, and resulting the not response to the treatment. And when there is a insulin receptor gene mutation, this produces the hyperinsulinemia and PCOS. YP gene mutation is the inhibited, and the result is the apoptosis, and as a result, the anovulation occurs. Now, the factors are the autoimmunity. Besides from the genetic factor or hormonal factor, autoimmune factor is the most important factor when there is a anovulation and there is a low level of the progesterone. And this low level of the progesterone is the overstimulated the formation of the estrogen. And this estrogen is responsible for the immune system activated. And there is a large number of the autoimmunity are developed. And the anti-nuclear antibody, anti-thyroid antibody, anti-tubulin antibody, and also the anti-pancreatic antibody is formed. And due to this autoantibody, there is a destruction of the cell and resulting the anovulation. And now the depression anxiety is related with the PCOS, and Darkus showing that the fourfold increased chance of PCOS in case of the resulting the depression. And the depression in case of the PCOS due to the sleep disturbance, there is a loss of appetite, loss of interest of the activity, and they may be depressed in the PCOS patient. And it is overcome by the assessment of the quality of the life and improve the communication with the patient by improve the lifestyle changes, improve the self-care, and improve the quality of the life. And depression is the overcome. Now, the anovulation disorder. The anovulation disorder is occur in the 75% of the patient. Anovulation, this is the factor that is the impact on the PCOS on the fertility. There is a resulting the anovulation, and this anovulation occurs in 75% of the patient, and is presented. And another factor that is the infrequent menstruation. Infrequent menstruation is occurred due to the estrogen and the progesterone. And estrogen and progesterone resulting the infrequent menstruation, and it also produces the RPL, and this RPL is the 25 to 54% patients suffer from the RPL, and it produces the when they is pregnant and she is a GDM and PET, preeclampsia, pregnancy-induced hypertension, and premature delivery, all the effect in the infertility. And there is a how the pathogenesis of the PCOS and how they produce the chronic anovulation. They produce the when there is a GABA is the increase and the opioid and dopamine are decreased, then abnormal pulse secretion of the GnRH and there is a high LH is produced. And these high LH is causes the hyperandrogenism and insulin resistance and resulting the chronic anovulation. And the impact of the obesity on PCOS, how the obese patient, and there is a large number of the peripheral aromatization and produce the androgen and produce the chronic anovulation. And another mechanism is the in case of the obese patient, there is a sex hormone binding globulin is the reduced, there is the increased androgen level and anovulation. And another factor is the insulin resistance. So there is the aromatization and there is a sex hormone binding globulin decrease and in insulin resistance. Three factors are responsible for the obese PCO patient leading to the infertility. And 10% have diagnosis with the diabetes and 35% patient having the IGT. And impact of the hyperandrogenemia and infertility. Due to the high LH concentration of the PCOS, the excessive production of the aromatase enzyme, there is a breakdown of the aromatase and the negative feedback effect on the hypothalamus and produces the less number of the FSH and decreased sensitivity of the FSH and thereby no mature follicle in the development. If when there is a 5 nanomole of the per liter in the serum testosterone levels, then we should go for the androgen excess are excluded. And when a serum testosterone level are identified, 20 to 30% patient and the free testosterone level was identified in the 50 to 60% patient in case of the hyperandrogenemia in infertility. And now the serum image and infertility. And serum image is related with the infertility because we know that the serum image level is typically increased in the PCOS patient, and therefore the image is the GnRH dependent image secretion, and And so that we find that the image is related from the preantral follicle and antral follicle. And these preantral and antral follicle is the produces the large number of the image, but deplete the inhibin B. When there is a depression of the decreased secretion of the in when there is a increased secretion of the inhibin B, and this inhibin B suppress the FSH. And so there is a image level is associated with the by the individual follicle rather than the increased number of the follicle. So the individual follicle produce the large number of the image. When the image level is the more than 2 picomole per liter in the individual follicle, then leads to the PCOS. And it is the diagrammatic picture that is the how the image level produces the PCOS. And there is a preantral and antral follicle produces the large number of AMH, that is this not the genre is gonadotropin dependent. So there is a large number of the AMH and large number of the androgen is produced. And these androgens aromatization to produce the estrogen, and there is a producer. And though there is a FSH is not here, so there is a no large number of the follicle, but no mature follicle is developed. So there is a polycystic ovarian syndrome is. Now the insulin resistance and infertility. And when there is a insulin resistance, we clinically diagnose the insulin resistance. The clinical factor, that is the body mass index, is more than 25, waist ratio more than 0.85, acanthosis nigricans and syndrome is present. Clinically suspect the patient is the insulin resistance, but biochemically, when the serum androgen level is the more than 150 nanogram per dl, then we go for the screening of the insulin resistance. And routine screening insulin resistance is not recommended. And routine screening of the IGT is the essential for the early diagnosis of the insulin resistance. And when the insulin resistance and hyperinsulinemia is diagnosed, and then we go for the insulin resistance index. This insulin resistance index, the cutoff value is the more than 2. When the cutoff value is the more than 2, then we suspect that is the patient suffering from the insulin resistance. Now the endometrial dysfunction and the PCOS. Now the endometrium also dysfunction, and resulting there is a early pregnancy loss and implantation failure. And why the endometrial dysfunction is occur in case of the PCO patient? In case of the PCO patient, endometrial dysfunction occur because there is a low luteal phase serum glycogen, and the insulin binding protein is the low in case of the PCOS patient. And there is a plasma endothelin level is the high. When the plasma endothelin level is the high and the glycogen level is the more, there is a imbalance between these two protein, and there is a endothelium are distracted, and there is a inadequate blood flow due to the low progesterone, and there is a luteal phase is defect, so there is a low progesterone, and the endometrial inadequate blood flow occur, so there is endometrial dysfunction, and it's also induced by the hyperinsulinemia, and so that is it is overcome by the metformin. And now the metabolic syndrome. Metabolic syndrome also PCO patients suffer from the 43 to 46% patients suffer from the metabolic syndrome. And out of 5, there is a 3 symptom or biochemical change and clinical change when present, then we call that is the metabolic syndrome. And PCO presentation, that is the we all know that is the obesity, insulin resistance, oligomenorrhea, amenorrhea, hirsutism, all of the presentation. And there is a type in the environment, that is the classic type, obliterative type, and hormoandrogenic type of the polycystic ovarian syndrome. And now, how to overcome this syndrome? And overcome the PCOS syndrome is like in hand, that when there is a, we discuss about before with the what are the factor responsible, that factor are the overcome by the, when the genetic factor is the involvement, there is a type is altered it, and when there is a obesity is the factor, then weight reduction is the, and lifestyle modification and the insulin sensitive regime should be used. And when there is a dietary habits, there is a natural organic food is given, and then correction of the dietary habit. And when the immune system is responsible, then the nutrition is should be done. And the accumulation of the toxin, then the stop the growth. And now this is the how to overcome the such as factor leading to the infertility. And there is the creating a multidisciplinary team. And this multidisciplinary team is the organized, that is the lifestyle plan, treatment of the hyperandrogeneous symptom, treatment of the endometrial protection, and there is the needs to the contraception, and there is a fertility counseling, and as well as the psychological behavioral support, nutritional counseling, and also needs to the metabolic screening and intervention. And now the treatment modalities, and the treatment modalities is the lifestyle change fastest, and then to the CC and the letrozole and insulin sensitizing agent, as well as the ovulation inducing. That with the IUI is the second line of therapy, and third line of therapy is the ART. In the how obesity and infertility, how to overcome, when the lifestyle modification is the first cut with the lifestyle modification diet, and there is the hypocaloric diet, that is the 500 calorie is the cartel from this diet, and there is the adequate protein, low fat, and the low glycemic control. And the recommended exercise is the 30-minute exercise in the 3 times a week. But when the diet and exercise are failed, and we are going to go to the anti-obesity agent, that is the orlistat, and associated with the metformin is should be recommended. And the bariatric surgery is when the patient are the morbid obese, then other measure at the fail, then go for the bariatric surgery. But it is not popularly used because it's delay the fertility, because the 12 months to take time for the stable of the patient. And with the correction of the obesity, there is a food habit. There is a food habit and the big breakfast group, and there is a comparison study and the big breakfast and the big dinner group. There is a finding that the big breakfast group at the 50% rise of the ovulation. This is the most of the calorie from the big breakfast, the 980 calorie from the breakfast. There is a vegetable and there is a high protein diet, and carbohydrate and fat are also mixed with it. And this is the big breakfast group and rising the 50% chance of ovulation. And avoid some drug, that is the white bread, pasta, sugar, and the fruit juice, and the saturated fat should be avoided from the diet. Now, when the patient presented with the hirsutism and infertility, and then the hirsutism and infertility with there is the hirsutism is due to the hyperandrogenemia. So first of all, we correct that there's the hyperandrogenemia by the cyproterone acetate, and then the go for the ovulation induction is recommended. And other spironolactone and the eflornithine is also used for the treatment of the hirsutism. Now, when the patient presented with the menstrual irregularities and infertility, and there may be an infrequent cycle, and the first we treated the infrequent cycle, then go for the fertility management. And first of all, we do the withdrawal bleeding by the progesterone, and followed by the ovulation induction. When patient presented with the hyperandrogenemia, then hyperandrogenemia pre-treatment with the clomiphene cyproterone acetate, and then followed by the ovulation induction is the treatment of the choice. When patient presented with the endometrial hyperplasia, then first there is a progesterone support, is a chronic anovulation, so thereby there is the luteal phase support with the progesterone. And when all these measure fail, and then anti-androgen combination with the insulin sensitizing agent in case of the menstrual irregularity is the most benefit, because metformin reduces the hyperinsulinemia, hyperandrogenism, and the insulin resistance. Now, the anovulation and infertility, my next speaker details about the treatment of the ovulation. So I skip these things, but additional 2 points are added with it. That is the anovulatory cycle, while the metformin restored the ovulation 50%, and the ovulation and menstruation and restored 50%. So the pre-treatment of the metformin enhanced the efficacy of the CC for the inducing the ovulation, and in acetylcysteine may also enhance the ovulation. Now the insulin resistance and the activity, and insulin resistance improve the improved by the metformin in case of the lean obese patient. And metformin also helps to decrease the C-reactive protein, or when there is a inflammation, chronic inflammation is responsible for the PCOS, it is treated by the metformin. And there is a when there is recurrent pregnancy loss, endothelium is damaged and endothelium is not prepared, then a metformin increases the blood circulation. Now, the myoinositol is also increases the a positive effect on the hyperinsulinemia and correction of the hyperinsulinemia, and help the correction of the infertility. And when the all is the measure, when the patient presented with the LH, how we tackle this patient, and the patient high LH, then we should correction first by the high LH. And high LH correction, that is the when the LH level is the more than 10 and CC is the resistant, gonadotropin is there is a hyperstimulation syndrome is produced and there is a recurrent pregnancy loss, then we go for the laparoscopic ovarian drilling. And this laparoscopic ovarian drilling is giving the 6 to 12 months following that ovulation rate is the 30 to 90% and pregnancy rate is the 6 to 80%. Some are controversial whether it is the gonadotropin is the use or there is a ovulation in LOD is the effective. There is the LOD is the effective because there is a chance of wages is less and there is a no intense monitoring is the required and there is a single treatment with the benefit for the 6 to 12 months. And problem in the ovarian reserve and the PCOS. What is the problem? That is a problem that is young PCOS and there is a aging PCOS. There is a two type of the problem. In case of the young PCOS, there is a basal FSH level is the lower. So there is the increase in inhibin production. This inhibin production suppresses the hypothalamus to produce the FSH. So there is a in young PCOS, there is a no developing follicle is present and follicle is arrest. But in case of the aging PCOS, there is a follicle is the hard follicle, that is the follicular pool is the reduced. So there is a inhibin B is reduced. There is a permits the FSH enhanced. So there is a when there is an FSH enhanced, the responsiveness of the follicle is more. So there is a ovulation occur, sporadic ovulation occur in case of the aging process, and there is a spontaneous pregnancy chances more in case of the aging PCOS. Now we go for the, when all these measures are failed, then we go for the ART treatment. And the ART treatment with the 1 to 2 cycle with the OCP. And criteria for the, we use the low dose protocol and close monitoring of the follicle. And the antagonist and versus the long protocol may be used. And FSH is preferable than the HMG and close vigilance for the Now, the pre-IVF consideration, when the patient failure, the gonadotropin therapy 6 cycle or IUI the 6 cycle, then you go for the IVF. And the failure to conceive after the CC or LOD, then you go for the IVF. When the low response and the high response due to the low dose of the FSH is used or associated male factor or G12 factor. And to prevent this such condition, we give the pre-treatment weight loss and the lifestyle modification and metformin or may be needed with the LOD. And after that, we are starting the IVF. And the challenging treatment of the IVF. The challenging treatment, that is the chance of an ovarian response is less in case of the PCOS patient and difficulties in adjustment of the gonadotropin dose. So it is the critical situation, that is the challenges in the IVF patient management in PCOS, and the increased risk of cycle cancellation and increased risk of the spontaneous pregnancy is the loss. That all are the challenges in the treating the infertility in PCOS patient by the IVF. And challenging management, that is the all these challenges are overcome by the when we use the antagonist protocol, that is favorable, and the careful titration of the gonadotropin dose should be used, and the measure for the prevention of the OHS and GnRH agonist for the triggering is used, and the single blastocyst transfer should be preferable, and all the and cryopreservation may be needed, and sometimes we use to the cabergoline to prevent the overcome these challenges. Now, another challenge is the PCOS patient are the more prone to the hyper-responder. And this hyper-responder, there is a when the 5,000 unit picogram per ml or serum steroid level, then we stop the cycle and cycle cancellation or to the costing. And we know all about the costing. And now the some other newer drug should be used to overcome the such a problem in case of the PCOS. That is the melatonin, inacetate, myoinositol, N-methylfolate, and alpha calcidolyl or chromium. And my previous speaker in that tell about these details by the adjuvant. So in the some drug we are used for the management of the PCOS. And now the take-home message. And the PCOS is the one of the common disorder affecting the woman with the reproductive age, and improving the infertility is the primary goal of the therapy. All women with the diagnosed with the PCOS should be
আপা কি আছেন? জেসমিন আপা? Most probably Professor Jasmine Manu Madam has lost her internet connection. Should I wait for a few 1 or 2 minutes for her, or proceed? Dr. Aditya, you have to unmute your mic. You have to unmute your microphone.
Yeah, you can wait. We can wait for another 2 minutes, madam.
Okay, we should wait
Before
for 2
that,
minutes.
I would just like to, because I take this opportunity to thank all of you, particularly Dr. Jasmine, to giving us this opportunity and to allow us to become the part of this webinar. Then secondly, as you know that we are running this webinar as far as this PCOS webinar awareness are concerned. In coming days, we'll be having others webinars related to PCOS also. So this is our first webinar in association with BSMMU. So we thank the entire team of BSMMU, particularly under the Dr. Jasmine Banu. And Madam Dr. Farjana, you are also doing wonderful job of your moderation. Previous speakers also, particularly Dr. Sakila and Dr. Kokila. Madam also, Dr. Jasmine also, she did a brilliant presentation. So we can wait for another 1 or 2 minutes till Madam comes back, or else we can go ahead and later on she may join us.
She is just joining us within 1 or 2 minutes, and thank Aditya for your excellent thankfulness to us. And this is really a good platform for sharing the awareness of PCOS in this month of September. And Dr. Aditya, for your kind information, we have a special guest with us, Professor Shala Khatun Madam. She is our national professor and one of the teacher and mentors of us. She is one of the most senior teacher of us. So,
Madam, good evening. Madam, good evening from me and Dr. Kokila. Please accept our regards, madam. Glad that you are here and you are witnessing what your juniors are doing. Hopefully, at the end, when question answering takes place, then you may give us your feedback, madam. Please stay back. We'll be finishing very soon. One more presentation left. And I would like to take this opportunity also to, I have witnessed Dr. Afroza Ghani's presence. and she is a part of our team, and it is all because of her. Our association with all our Bangladeshi friends, it went up like anything, and that is the reason for which also we are here. Special wishes to for Dr. Rokeya Begum, madam.
Madam
I
is
think
getting back.
okay, madam. Madam, you came.
Professor Jasmine Mano, madam, has are with us, is with us. So, would you please, madam,
She may
unmute
conclude.
your?
She may take her
Yes,
last
you can
slides.
conclude.
Yeah.
Madam, you have to unmute.
How far did you start?
Yeah, we are waiting for you, madam. Yeah.
Okay, start.
Okay, you can conclude your last slide, madam. Yes, take a miss. You can
Yes.
conclude your last. Okay, go ahead, madam.
We can conclude the last slide. That is the take-home message. Is the PCOS is the one of the most common disorder affecting women with the reproductive age group, and improving fertility is the primary goal of the therapy. And all women diagnosed with the PCOS should be screened for the thyroid disease, hyperprolactinemia, type 2 diabetes, hormonal abnormalities, and the non-classic congenital adrenal hyperplasia. Maintaining a healthy and the active lifestyle may decrease associated infertility. The recommended first-line therapy is the ovulation induction. Chronic low-dose step-up gonadotropin is still recommended in the women with the PCOS in ART. ART is the challenging management to overcome the effect of the PCOS. Now, thank you.
Thank you, madam, for your excellent and outstanding presentation. Now, this is the time for Dr. Aditya. He will speak on ovulation induction in PCO. As we know, ovulation induction is an art in non-ART and as well as ART patient. Use of ovulation inducing agents and its monitoring has become a core part in the treatment of infertility. Application of various oral and parenteral ovulation inducing drug and monitoring by transvaginal sonogram and hormonal understanding has changed the concept of treating the anovulatory patient. Variety of drugs and protocols are available, and Dr. Aditya will speak on the recent modalities of ovulation induction on PCOS. Dr. Aditya Dash is the fertility consultant of Care Fertility Center of Bhubaneswar, Odisha, India, consultant intrauterine surgery, Spars Hospital, Bhubaneswar, clinical IVF and hysteroscopic trainer, Embryo Edu International, special interest on embryo freezing and biopsy and hysteroscopy. He was the invited speaker and faculty in several national and international conference, workshop, hands-on training programs and webinars. Invited faculty in international workshop on clinical IVF and hysteroscope. He is the editor of Jofi Mofi NIFS newsletter. He is the founder member of OFS, Neo India Fertility Society, and founding member of World Hysteroscopy Forum. He is the founding member of Asia Oceanian Fertility Research Program and member of ISHAR, IMA, and FOXY. Now, may I request Dr. Aditya Das to speak on ovulation induction on PCOS.
Once again, thank you, Madam Dr. Farjana, for this kind introduction. And once again, I take this opportunity to thank Dr. Jasmine, Madam, for her invitation, and for which this webinar is happening, and all the my juniors, my friends, and all the senior faculties present over here. And I congratulate all the speakers who had a wonderful presentation this evening. So I'll just take a few minutes of time, definitely more than 15 minutes. Please be patient with me. So let me start, and I welcome all of you, and my special greetings from my state, Bhubaneswar. And it is very well connected from Dhaka to Kolkata. Then you can catch a connecting flight to Bhubaneswar. So as we know that ovulatory dysfunction is a commonest disorder, and its prevalence is 5 to 15% among normal population and 20 to 40% among the infertile women. So WHO has classified this anovulation into 4 groups, and PCOS comes under the category of 2, hypothalamic pituitary dysfunction. So it is a dysfunction where you may find normal estradiol level and normal FSS. So it is such an enigma that we always like to agree to disagree, because, madam,
May I interfere?
anything?
Dr. Aditya, would you please share your slide?
Okay, just a minute, madam.
Not able to see your screen.
Okay.
Yeah.
Okay. Sorry for the interruption. Let me start from again my first slide. So I think all of you are able to see my slide, right? So greetings from my
Right.
state, and my place Bhubaneswar is very well connected with Dhaka via Kolkata. So as you know that ovulatory dysfunction, it is the commonest causes of infertility, and PCOS is by far the most frequent condition. Prevalence is around 5 to 15% in the normal population and 20 to 40% among the infertile couple. WHO has classified this anovulation into 4 categories, and polycystic ovary falls under group 2, hypothalamic pituitary dysfunction. So it is a dysfunction, and where we can find normal estradiol and normal FSS, but it is an enigma, and most of the time we like to agree to disagree, and these disagreements have continued till today, because criteria for diagnosis keeps on changing and management guidelines also keeps on changing. So with this, let me try and give an overview how best ovulation induction can be done in PCOS. And as you know, recently 2016, there was a review article in the Fertility Sterility 2016. They have mentioned about different phenotypes. Actually, they summarized how really difficult is ovulation induction in PCOS. All the patients are not same. Depending on their phenotypes, they behave differently to different ovulatory induction agents. So they have categorized A, B, C, D category, and out of which, the A category is the most difficult one, because A category phenotype, you will be having hyperandrogenism, chronic anovulation, and polycystic ovaries all together. So that is why A1 is the most difficult one, and D1, where only the patient is having chronic anovulation and ultrasound finding of PCOM, they are the easiest one. So in 2009, again, Indian Journal of Endocrinology and Metabolism, more or less the same kind of phenotype study they found among Indian females. And they found that the group A is the most prevalent and more likely to be clomiphene resistant. And it constitutes around 45.26%, whereas phenotype D is the least severe or the mildest presentation of the PCOS. Once we divide these patients into this kind of phenotypes, we can do the diagnosis properly and plan a proper treatment, and prognosticate the response. But common clinical conditions, we see 2 patterns: peripheral cystic pattern and general cystic pattern. You can see the left side, the most common what we see, that peripheral cystic pattern. There we can associate it is associated with abnormal only gonadotropin secretion. But where a general cystic pattern very difficult to crack, and because it has some ovarian steroidogenous disorder. So what is the meaning of ovulation induction? It is the stimulation of ovulation by medication. So stimulation of development of an ovarian follicle to reverse anovulation or oligoovulation. Also, it can be used in the sense of triggering oocyte release from the relatively mature ovarian follicles. So the patient is not ovulating, so we are inducing ovulation. The aim of the treatment is to shift this hormone level away from LH insulin leptin driven excessive androgen synthesis towards an FSH driven final development of a dominant follicle. So our aim is monofolliculogenesis, when ovulation induction is carried out for simple procedures like timed intercourse or IUI, and ART cycles, we are planning for control ovarian hyperstimulation. So in all these cases, when we are planning for monofolliculogenesis, we have to do everything in a narrow FSH window. But in a multifolliculogenesis, our threshold of the FSH level should be high and the window should be widened, so that more the follicles can be recruited, and later on it will get into multifollicle generation. In PCOS, before we start this induction, before we go for the pharmacological intervention, there is a non-pharmacological intervention, and it has been well accepted. So lifestyle intervention and weight reduction has to be done. And thereafter, some estrogen receptor modulators like clomipene and letrozole can be used. Metformin can be added, and other adjuvants can be added. Then we may have to think laparoscopic ovarian diathermy versus injectables, particularly in LH resistant cases or CC resistant cases. So how about the weight reduction? Already madam has discussed nicely that once the patient goes for gradual weight reduction, it increases the insulin sensitivity and sensitivity, naturally leads to reduce hyperinsulinemia, improves the hormonal imbalance in the ovary and reduces androgen dominance. And in most studies, they have found sporadic ovulation if there is a decrease in weight by 5 to 10%, and later on regular ovulation also takes place. So it has to be a steady decrease in the weight, more important than the what weight she has lost. There should be a steady decrease, and weight loss medication can be tried because it has an additive effect and resulting in ovulation and conception. Bariatric surgery has a beneficial effect on PCOS-related anovulatory, particularly in morbidly obese patients. Myoinositol and chiroinositol have been already discussed, but the doses should be myoinositol 2 gram, and for chiroinositol it is 0.6 gram, both taken twice daily, and treatment duration is reported to be between 2 to 6 months. Metformin has significant ovulatory stimulatory effect compared with placebo, and it reduces the risk of OHSS, but it is inferior to clomipene, and the dose is 1500 to 2500 milligram per day. Initial part of practice, we have seen people used to give metformin as a first line of drug. That is what I want to remind, that it is inferior to CC. So what are the common ovulation induction agents we are using? Oral agents and injectables. In oral agents, we are having clomipene citrate. It's a selective estrogen receptor modulator, and letrozole is an aromatase inhibitor. Other agents like tamoxifen. And among the injectables, lot of different kind of gonadotropins are available: urinary, highly purified, and recombinant. Then in that we can have HMG and FSH. Usually FSH injections are available in the recombinant we can have it recombinant FSH, but whereas we don't have HMG, recombinant HMG till yet. Yes, we have recombinant LH, and apart from that also we can use GnRH agonist and antagonist in special cases. How CC really works? CC blocks the estrogen receptor in the hypothalamus. So once it blocks the estrogen receptor in the hypothalamus, there is estrogen negative feedback is inhibited. That leads to increased FSH and LH. And when increased FSH causes to more follicular development and more estrogen. So hypothalamus senses this, and there is positive feedback on the surge and leads to LH surge and ovulation. As you know, 62% of N-clomipene. Clomipene citrate has two parts, and the N-clomipene is the most active part, and it is mainly responsible for the ovulation. But it has a negative aspect, that it is the long half-life of clomipene citrate, around 5 to 7 days. So what are the prerequisites before CC therapy? We should have a proper history examination, and duration and the cause of the infertility should be known. Evaluation of the male factor, particularly we should have a normal semen analysis mainly, and prolactin levels and thyroid function test have to be done. If it is abnormal, that has to be corrected first. And we should know that there is an intact HPO axis, as it is metabolized in the liver, LFT and adrenal functions has to be seen. And how about the tubal evaluation factors? It has not to be done initially unless otherwise there is sufficient reason to do so. So if there is some history of some disease, previous surgery or previous CC failure, or there is history of pelvic tuberculosis, if there is sufficient reason where you see that there may be some cause of tubal blockage, in those cases only tubal evaluation has to be done. As you know that doses of CC, commonest dose is 50 milligram to 100 milligram. If we go beyond 150 milligram, we don't get good result, but the highest dose we can go till 150 milligram, usually started between day 2 to day 3 for 5 days. You can try for 3 to 6 cycles, and it is safe and easy to monitor with least side effects. So this is what the diagrammatic representation. You can have started from day 2 for 5 days. You can start with 50 milligram per day. Later on, you can also increase with 100 milligram per day. Start doing TVS ultrasonography for folliculometry from day 8, or every alternate day you can do day 8, day 10, and day 12. And once the follicle becomes around 18 to 20 millimeter, you can think of giving SCG, but giving SCG is not mandatory. So or else we can monitor this growth by doing mid-luteal serum progesterone. If it is more than 10 nanogram per ml, it is a sign of ovulation. Or serum estradiol can be measured, and each mature follicle they secrete around 200 to 300 picogram per ml. So better monitoring is TVS, but best monitoring if you go both TVS and some hormonal studies. Efficacy of CC, as you know that it is ovulation induction rate is around 70 to 80%, but clinical pregnancy rate, though it is written 70 to 75%, but it is less. So, but it has a multiple pregnancy rate of 10 to 20%. So as you see that as we have increased the CC doses beyond 150, you see that successful ovulation rate has also gone down, as well as the cumulative conception rate. So how many cycles we can have? So you start with 50 milligram, no ovulation, you increase the dose to 100 milligram. Thereafter, you can go to 150 milligram, but mostly in our clinical practice, we give maximum till 100 milligram per day because of its profound negative effect on the endometrium. So you try this kind of protocol for 2 to 3 cycles. If there is no response or there is suboptimal endometrium, no result, no ovulation, in that case, you can think anti-estrogenic effects like nausea, vomiting, bloating, and breast tenderness, and 2% visual disturbance in scrotoma may be there. So what are the negative effects of cysteine? It is all because of the longer half-life, that is 5 to 7 days. It causes endometrial thinning and poor cervical mucus, and 15 to 40% cases also you can have the resistance. It can lead to in 10 to 20% cases we can have multiple pregnancy, and mild OHS is also relatively common. But ovarian cancer, the relationship, the causal relationship is almost no. So what are the predictors of failure in this kind of CC treatment? Mainly high age, obesity, BMI more than 30, hyperandrogenism, prolonged amenorrhea, high fasting insulin and leptin, and lower insulin growth factor binding protein 1. So what do you mean by clomiphene resistance and clomiphene failure? Clomiphene resistance means you have increased the dose, but there is no ovulation. So failure to ovulate with 3 months, use of 150 milligram for 5 days, up to 150 milligram, you have given the highest dose, but still there is no ovulation. However, clomiphene failure, we have given clomiphene for the induction. Induction has successful, ovulation has taken place. The patient fails to conceive even after 6 months. So what is the treatment, or what is the next step, what we can do about that? So we have to add metformin, we may switch over to gonadotropin cycle, or we may think about doing ovarian drilling. What are the other CC protocols? Some people have advised these kind of 2 to 3 new protocols, and they have found that these kind of protocols can be used in this kind of CC failure cases, and they have seen better pregnancy rate, like adding 100 milligrams CC daily 5 days before the periods. Suppose that these kind of patients are having, you may have to induce the uteral bleeding. So once you give the medroxyprogesterone acetate, once medroxyprogesterone acetate is finished, that day onwards you start the clomiphene citrate before she gets her period. So 5 days before she gets her period, start the clomiphene citrate 100 milligram daily. And there it has been concluded that luteal phase administration of CC in patients with PCOS leads to increased follicular growth and endometrial thickness. So they have witnessed increased follicular growth and endometrial thickness, and that may later lead to higher pregnancy rate. Another protocol, CC step-up protocol. First 5 days you give CC 50 milligram per day. If it is non-responsive, then doses you can increase to 100 milligram per day for 5 days. So first 5 days 50 milligram, thereafter next 5 days you give 100 milligram. So again, they have found that step-up protocol has a significantly shorter treatment period without any detrimental effect on the ovulation and pregnancy rates. Now, if CC doesn't work, nowadays we can switch over to letrozole, but nowadays so many recommendations have come that from the very beginning, we have to think about starting letrozole, not the CC. Initially, it was withdrawn from the Indian market 2012. It is because of the teratogenicity issues. And later on, so many studies came and they found that congenital cardiac anomaly is less frequent in letrozole group. Several meta-analyses came, all were in the favor that these claims that letrozole causes cardiac anomaly, these were not substantiated. So later on, they had to reintroduce the letrozole into market. So it is an aromatase inhibitor, so it prevents conversion of androgen to estrogen. It's the last step of aromatase enzyme. You might have, you know that when the androgen to estrogen synthesis takes place. Last step is aromatase enzyme. Once you inhibit the aromatase, so it prevents conversion of androgen to estrogen and leading to high FSH. But is the advantage is its half-life is only 45 hours. So it doesn't block the estrogen receptor, so no detrimental effect on the endometrium. Negative feedback mechanism not turned off. Most widely used nowadays, and dose is 2.5 to 5 milligram per day. You can give it from day 3 to till day 7 and free of any side effects. So several groups, they have compared some of the groups, they have found that multiple pregnancy and abortion was significantly lower. It is because of monofollicular development, and pregnancy rate with letrozole was more than thrice than the natural or CC stimulated cycles. So they have found that it can be used in CC failure cases, thin endometrium with CCU, and in ACOG 2016, they even said that it can be considered as first line of drug in PCO. So if we compare CC versus letrozole, main thing is that CC causes profound effect, adverse effect on thin endometrium, causing thin endometrium and altered cervical mucus, and it decreases the uterine blood flow, for which the miscarriage rate is high and OHS risk is high, and multiple pregnancy rate is high in CC group. So despite the promising results with the letrozole, neither letrozole nor metformin is approved for the treatment of anovulation in many countries, and it is outrightly prohibited in several other countries, and it is prescribed off-label. So ACOG 2016, they recommended that letrozole should be considered as first-line therapy for ovulation induction in patients with PCOS and when BMI is more than 30 because of increased low birth rate compared to CC, live birth rate in CC. What are the other selective estrogen receptor modulators were used? Once upon a time when letrozole was not in the market, people started searching for several selective estrogen receptor modulators like tamoxifen, raloxifene. But further extensive studies are required to prescribe these medications as the first line therapy. Now, how about the second line therapy like gonadotropin? The aim is to recruitment of multiple follicles. Either we can have different gonadotropins like HMG and FSH, we can have urinary or recombinant. So main use, as I said, hypogonadotropic hypogonadism, type 1 WHO anovulation, directly we can start with gonadotropins. But other indications are like CC resistant anovulation, unexplained infertility, superovulation in older men. We may think about starting gonadotropins from the very beginning. So injectable gonadotropins can be started when no pregnancy after CC ovulator cycles, suboptimal ET, no response with the CC highest dose, and WHO type 1 anovulation. So different kinds of preparations are there. Which gonadotropin to be used? Just a summary kind of thing, we can use it in our practice like that. When we are using CC, we can use both FSH or HMG. Standard ovulatory IUI or control ovarian stimulation, we can use both FSH or HMG. But in hypogonadism, we have to use HMG. Patients with high FSH, we have to use HMG. FSH in patients with high LS, particularly PCOS with high LS, there we have to start giving FSH, and we have in a clinical setup, we have seen FSH works better than HMG, particularly this kind of high LS PCOS cases. There are several protocols. Either you increase the dose, or first you increase, later on you decrease it. You start with the higher dose, go for the lower dose, or else from the very beginning, start with the very lowest dose and maintain that. Because the problem is that multiple follicular development. Because here we are inducing the patient. Our intention is to have only one follicle. So if you start with high dose, it will happen that multiple follicles will, and it would be very difficult to convert those kind of patients to IVF. We may have to cancel the cycles, and there's a risk of OHSS. So what are those gonadotropin cycles, non-IVF gonadotropin cycles? What should be the starting dose? Suppose we are not doing IVF, we are talking about the only IUI or ovulation induction. So what should be the starting dose? How we can decide the dose? By looking into the age and body mass index, by looking into the antral follicular count and existence of PCS, AMH value, and what is the response previously. So low dose step-up stimulation, it is very popular among the infertility specialists when handling with difficult kind of PCOS. So we start dose at the least amount of dose, that is 37.5 to 50 IU. Then you can increase this dose after 7 days by another 37.5 IU, and till the dominant follicle becomes 18 millimeter and endometrium more than 7 millimeter. So if you stick to 37.5 millimeter, 37.5 or 50 IU of recombinant RFSS and be patient enough, definitely after 7 to 10 days, this kind of patients, they will ovulate. So many studies they came, they said that higher potency and better clinical efficacy with the recombinants, and they said that because recombinant is the identical to natural FSS, its consistency, no LS activity, so they said it is superior, but the disadvantages are it's the cost and still there is a risk of OHSS. So there were several studies they found it is superior. Then when to do SCG, when to give SCG as ovulation trigger, though it is not mandatory to give SCG as an ovulation trigger, but usually SCG is given when we are suspecting some luteal phase defect, and definitely it corrects the luteal phase defect also to an extent. So mostly when the follicle becomes around 18 to 20 millimeter, but when oral agents have been used, particularly CC and letrozole cycle, the size will be more, 23 to 20 millimeter, and gonadotropin cycle, the size will be less, around 16 millimeter. So there are several Doppler parameters, particularly when the peak systolic velocity increases or resistance index, it decreases. When the vascularity becomes more, both endometrial as well as perifollicular, then considering all these parameters and triple line endo more than 7 millimeter, we give SCG as an ovulation trigger. 5000 IU is recommended, or 250 microgram of recombinant SCG. So Cochrane database says that it is inadequate to recommend or refute the use of SCG as an ovulation trigger in anovulatory women treated with CC. Other agonist triggers, to prevent OHSS. In that case, we look for another alternative to SCG. In that case, we can give leuprolide 1 to 1.5 milligram. So dual trigger can be given so that GnRS will prevent this OHSS, and SCG will give whatever the luteal function that can be rescued by added SCG. So dual trigger described by Shapiro, both GnRS agonist followed by SCG, you can give SCG 1000 to 2500 IU. So without this trigger, if more than 2 mature follicles or estradiol level is more than 3000 picogram ml, in that case we need to avoid giving SCG so that we can prevent OHSS. To summarize the how to prevent OHSS, we have to titrate our stimulation protocol, use of less aggressive stimulation protocol, monitoring ovarian response is very much essential. If more than 2 follicles abort cycle or convert to IVF, we can start using antagonist protocol, we can use agonist trigger, and we can go for elective single embryo transfer, and we can follow all the principles of OHSS free clinic. So risk of OHSS, yes, it is abundance, like Levant ruins many. So early OHS, and we can have late OHSS. Early OHSS because of the ovulatory SCG, which happens within 3 to 7 days of SCG administration, whereas late SCG, it presents 12 to 7 days after SCG, induced by endogenous SCG from the trophoblast of the implanting pregnancy. How about laparoscopic ovarian drilling? It is also a second line therapy in comparison to gonadotropin. Both gonadotropins and laparoscopy ovarian drilling people have given equal importance, but mostly it is should be done in LS resistant cases, and it is cost effective, and it also leads to low risk of multiple pregnancy. So just few points about IVF in PCOS. In the resistance PCOS related infertility cases, we may have to transfer the patient, we may have to consider IVF in this kind of patients. PCOS is seen in combination with tubal factor infertility or significantly reduced sperm quality. If other associated factors are there, then we may have to start thinking about IVF. And IVF in patients with PCOS produce good result, as in particularly tubal factor infertility. The risk of OHSS is significantly increased even though we use antagonist protocol. How luteal phase support? Most of the cycles we give luteal phase support in the form of progesterone or dydrogesterone, but SCG should not be given. But there are several studies, they say clomiphene citrate, they produce adequate LH. So in the clomiphene CC induced cycles, we should not give progesterone as a luteal phase support. So as you know, different ovulation induction agents, and just to summarize, you have seen CC plus metformin. I think the FSS works better. It is the best, but it is expensive, costly, more monitoring is necessary. Next to FSS is letrozole, and next to letrozole is CC plus metformin. But whereas the multiple pregnancies are concerned, FSS group has the highest multiple pregnancy rate. But the live birth rate, letrozole group, who has the letrozole group and FSS group having the more or less the similar kind of live birth rate. So in 2019, there was a recommendation. It was actually in 2018, and it was published in 2019. evidence summaries and recommendation from the international evidence-based guideline. So this one, so they summarize that the first line of the non-pharmacological management should be lifestyle intervention. First line is the lifestyle, and that is the non-pharmacological. And when it doesn't work, then thereafter we have to consider pharmacological management like first line. And in that case, letrozole comes the first, thereafter followed by CC, followed by CC plus metformin. Then metformin, the last is the gonadotropin. And in the second line, pharmacological or surgical management, they have given equal importance to gonadotropin and LOD. So to summarize, treatment possibilities for unobligatory infertility in women with PCOS are many. Based on the success rate, complexity, and adverse effect of different treatment options, following algorithm may be followed, which I had discussed earlier. Initially, lifestyle intervention. Later on, we can think of starting adjuvants and ovulation induction initially with the letrozole. Later on, we can start thinking about FSH stimulation or LOD. And the last but not the least is the IVF. So ovulation induction is must even for subtle ovulatory disorders. Cycles need to be monitored to prevent complications and to get the best results. And we have to individualize the stimulation protocol so that we can increase the effectiveness to decrease the complications. With this, I end my slide, the presentation, and I all of you, I promise you people after Corona pandemic, please visit my state Odisha and my place Bhubaneswar. Thank you very much.
Thank you, Dr. Aditya, for your excellent scientific updates. Now, this is the time for panel discussion. We have 4 questions for 4 panelists, and you have any queries, audience, if you have any queries, you can put it in the chat box so that the speaker can answer. And special thanks to Dr. Kokila for your kind support to meet the queries of the audience. Now we will move to the panel discussion. First question to Dr. Shakila Ishrat. Mrs. K, she is 20 years old lady, presented with primary subfertility with infrequent menstruation and sonographic evidence of polycystic ovary. But during menstruation, she is having severe dysmenorrhea. She is also having dyspareunia. What is the possible diagnosis? Is there any possibility of having coexisting endometriosis? Dr. Shakila Ishrat.
Very rarely we get patients like this. However, severe dysmenorrhea is existing, but severe dyspareunia we do not have. And in that case, sometimes it came to our mind that whether endometriosis and PCOS coexist. And therefore, we searched for papers, and we got one paper which studied laparoscopic findings of PCOS compared to other patients, and they concluded that endometriosis, particularly in stage 1 and 2, significantly contribute more in case of PCOS than in the controls. And they explain it in the way that since there is often prolonged and severe menstruation, and when it is combined with excess estrogenic states and low progesterone state, that this can be explained. However, a further research or further investigation is necessary.
Okay, thank you, madam, for your nice explanation. My next question to Dr. Kokila. The patient is Mrs. A. She is 25 years old lady, presented with 5 years of primary subfertility with infrequent menstruation and hirsutism. Her BMI is 28 kg per meter square. She is not responding to clomiphene citrate, which was prescribed by a local doctor. On infertility workup, other factors are normal. What would be the next treatment options? Is there any role of adjuvant? How appropriate is the idea of ovulation induction only with metformin and adjuvant? Dr. Kokila.
Yes. So I understand that the patient is only 25 years old and for a married a period of 5 years. And our BMI being the 28, she is on the obese side and she is not responding to CC. So I assume that she must have some insulin resistance. So now clomiphene citrate was prescribed by a local doctor, but the exact duration and the dosage of clomiphene citrate is not described here. So what I understand here, if they have been treating her with clomiphene citrate with the maximum dose like 150 milligram up to 150 milligram for 3 cycles. So I understand that she must be a CC resistant case. And considering the other factors being normal, like no other coexisting diseases and the tubal patency has been done, what I understand, like when you say that all the factors were normal, then the next treatment would be I would go to another new drug, that is letrozole, what we've been talking about, which has been recently and newly accepted as the first line of treatment in PCOS due to its advantage of monofollicular genesis and avoiding multifollicular genesis. So I think next drug what I would try on her would be letrozole at least for 2 to 3 cycles and see the response, right? And then I would think about using injectables and other treatments like drilling. And coming to the next question, is there any role of adjuvant? Yes. As I said, BMI is 28 and I consider it as insulin resistance. Probably I would definitely put her on metformin and other adjuvants like minoxidil and inoxidil and other combinations which may contain vitamin D and coenzyme, many more things which do have some evidence-based studies and which are not found to be detrimental to the patient. So probably I would definitely put them on metformin and some adjuvants. So how appropriate is the idea of ovulation induction only with metformin adjuvants? So I don't think that metformin adjuvants can be used as a first line of drug for ovulation. Probably metformin and adjuvants can be used only as a co-treatment along with metformin, letrozole, or along with ovulation or ovarian drilling. Am I clear, Dr. Farzana?
Thank you very much. Thank you for your kind explanation. Now, this is the question for Professor Dr. Jasmine Banu. The patient is Miss F. She is 15 years old girl, presented with infrequent menstruation. Her BMI is 28 kg per meter square. Now she is worried about her high serum AMH level, 9 nanogram per ml, which was done during her biochemical workup. Is there any relationship of high serum AMH with menstrual irregularity? And how high serum AMH could be reduced? Professor Dr. Jasmine Banu. You have to unmute, madam.
The patient, 15 years girl, the infrequent menstruation and BMI is 28. So there is the first option, there is the weight reduction and AMH is related, is there, AMH is related and more than 9. When the, you know that the AMH when the more than 9, that is the resistant to other drug and not it responds to the other drug in case of the 9, and it is the cutoff value is the 4.6. When the AMH level is the 4.6, the patient usually suffer from the menstrual irregularities. So after that, we cautious that when the patient is AMH is more than say 4.6, then we go for the ovarian morphology. And now when the AMH level is the more 4.6, that is the changes of the ovarian morphological change that is the correlated with the AMH level and the ovarian morphological change, and as well as the high chance of the menstrual irregularities. It is clear that when the AMH level is the more than 4.6 and ovarian morphological changes simultaneously occur, both are correlated with the menstrual irregularity. If when the AMH level is less than 3.5, but there is no morphological change usually occur and there is the menstrual irregularity not so. And how the serum AMH level could be reduced, and there is a first option, that is the when serum AMH level is usually related with the LH, high LH and high androgen level, and previously we said that the AMH level is generase dependent, and it is secreted from the granular cell, that is the parental and antral follicle. This parental and antral follicular secretion is regulated by the inhibin B, and the inhibin B is the more than MH level is the more, and there is a suppression of the FSH. So there is a serum MH is reduced by the entry androgen, because the parental follicle and antral follicle are regulated with the androgen. So first targeted to reduces the androgen level and then reduces the MH level. So when the MH level is high, for the correction of the menstrual irregularities, they first treated with the entry androgen level, and also use the metformin to reduce the MH level.
তারপর এসে আবার দেখেন যে হ্যাঁ বাচ্চার হার্টবিটটা পাওয়া যায় কিনা। এখন কিন্তু বাচ্চার হার্টবিটটা পাইনি। হ্যাঁ, এর জন্য একসাথে বেশি হচ্ছে না। সমস্যা হলে তো ফোন নাম্বার আছে।
একটু ডক্টর দিলকুশা যদি আপনি মিউট করেন, আপনার কথা শোনা যাচ্ছে। ডক্টর দিলকুশা একটু মিউট করবেন।
So the MH level, high MH level is reduced by the first option is the entry androgen. There is a cyproton acetate and ethinyl estradiol combination is used to reduces the MH level. And then another option is that to reduce the androgen level, and level is the related with the insulin resistant and treatment. And now a recent study shows that the many another option is the melatonin. Another is the melatonin is showing that the AMH level is the reduced. Is the recently it is used to reduce the hyperandrogenism, hyperandrogenemia as well as the AMH level. So we use the first of all the anti-androgen, that is the cyproton acetate. Second option there is a metformin, and third option is the melatonin should be used. Is clear?
Thank you very much, madam. To the audience, please আপনারা কি আপনাদের মাইক্রোফোনগুলো একটু যদি মিউট করেন আমাদের জন্য ভালো হবে। Audience,
এত সাউন্ডে প্রবলেম হচ্ছে।
Now finally to Dr. Aditya Das. Your patient is Mrs. A. She is 25 years old with diagnosed PCOS, presented with 8 years of primary subfertility. Husband lives abroad now. They are living together for the last 2 cycles and did all the infertility workup, which were normal. Her husband will leave after 1 month. Now she is at her 46th day of menstrual cycle. Her serum beta is negative for pregnancy. Is it possible to start ovulation induction now? If so, how? প্রফেসর রোকেয়া ম্যাডাম, আপনার দৃষ্টি আকর্ষণ করছি। ম্যাডাম একটু মিউট করবেন। For your kind information, we have Professor Rokeya Begum with us, a senior, very eminent gynecologist of our country. Madam, welcome to our webinar. Dr. Aditya Das, would you please answer the question?
As far as the age is concerned, 25 years and the marital years 8 years. So I need not have to consider first 3 to 4 years of her marital life, because by that time she was too young for to become a mother. So mostly last 3 years, I will consider just last 3 years of her last marital life. And as husband was staying abroad and they have started living together for last 2 cycles, though she is a known case of PCOS, all the investigation have to be found to be normal. And in this case particularly it becomes a social issue, because husband will leave after 1 month, so they would definitely like to conceive. And in that case definitely in this kind of cases, what usually happens in South Asian countries, that we have to induce them, and we may have to counsel them for an IUI. So if they're as far as her her cycles have been delayed by 15 days, definitely I will add some medroxyprogesterone acetate as an withdrawal bleeding. And before that I would have counseled about ovulation induction and also IUI. And I would request the patient and the husband to stay back for another 2-3 months so that they can complete their, at least the lady can become positive. So if there is urgency for the husband to return back, in that case, definitely I have to think of doing both ovulation induction and IUI together. And for future IUI, I may counsel the husband to go for semen freezing, so that in his absence later on also we can do ovulation induction with IUI. That is what my plan would be for this couple, madam.
If she wants
Yes.
to have pregnancy in this cycle,
So first
is
initially,
there any possibility to
because
do
her
ovulation
cycle have
induction
been,
without uterine bleeding?
we can give, we can start just like luteal phase CC, we can start with CC directly, but the response may not be that adequate and may not be as per our expectations. So definitely she should have get her period, and thereafter I'll prefer to start CC. But there is nowadays that luteal phase CC induction has been there, but it is not for this kind of prolonged period cycles. There they have suggested you have to give medroxyprogesterone acetate, and on the last day of medroxyprogesterone acetate we can add CC, so that next month if there is inadequate response, this luteal phase CC may help to develop a good follicle, so that they can try for a natural intercourse, or else if they are willing, they can go for IUI also along with CC induction.
Okay, thank you, sir, for your explanation. Now, at the end of our session, if any speaker want to share any information with us, important information with us, you can share it with us.
Hope I got disconnected for a brief period of time, madam. I hope I am
Thank you.
loud.
If you want to share any interesting topic, or you want to share anything important with us, you can share it.
Currently, we don't have much information. Just I would like to share about one patient. Usually, it happens in our India, in my state also. Patients with PCOS, actually, they don't get proper treatment because the initial part of their life they don't visit to a proper doctor. So initially, we start giving all these kind of adjuvants, and we never ever do the proper evaluation. And once the marital life becomes 12 years, 15 years, thereafter when they become to the age, enter the age group of 35 to 40, then only they visit the fertility consultants. So these kind of lean and thin patients with history of hirsutism and very LH resistant cases, very difficult to ovulate them with CC or letrozole. So in those kind of patients, don't lose heart. Please go ahead, counsel the patient properly, make her understand the pathophysiology of the PCOS and how this kind of cases can be cracked. So go ahead with low dose of recombinant FSS in this kind of patients. Initial 1 or 2 cycles she may fail, and there may be 10 to 12 doses. She may have to visit to the hospital, repeated hospital visit for follicular study. Later on, you may face, both the patient and the doctor may face negative result, but it may happen this kind of patients also, they conceive within the 2 to 3 months of chronic low dose step up protocol without any IUI. So don't lose heart. Start doing evaluation. These kind of patients, start giving chronic low dose step up protocol with recombinant FSS, and it works. And I would like to give this advice to all my juniors, and they can also try. But you do proper follicular monitoring so that you can decide about the dose as well as the number of the doses. And if any further modification has to be done, directly taking them for IVF is not a good idea, madam, because
Thank you very
the
much.
marital life is for 12 to 15 years, multiple ovulation induction cycles with all our established gynecologists. That doesn't mean that she should be directly taken off her IVF. Just see if adequate or proper or the real ovulation induction has not been done, then you start from the basic and do the ovulation induction. Maybe with your initial 2 to 3 ovulation induction, they will conceive, which you as well as Jasmine madam as well as Sakila madam might have noticed. Still the message is that we can give them a proper trial. If the proper trial has not been given, we cannot waste their time. That doesn't mean that we will directly take these patients for IVF. Even though our IVF success or our standard of the IVF lab is very good, still then if there is any scope, we can give them a proper ovulation induction.
Thank you very much, sir. This is a great privilege to thank all the distinguished and participants who have visited this memorable webinar. My words are not enough to express the gratitude to Professor Shala Madam, Shala Khatun Madam, Professor Rokia Begum Madam, and Professor Gulshanara Madam, our senior gynecologist, our teacher, our mentors. I would like to thank all the speakers, especially to Professor Jasmine Banu, who has taken all the burden to make the program success. And I would like to thank all the speakers for their thought-provoking, informative lecture in this perfect platform. My heartfelt thanks to, on behalf of Reproductive Endocrinology Department of Bangabandhu Sheikh Mujib Medical University, to ACI Pharmaceutical Ltd and Raj TV for their enormous support in this webinar. Thank you again for making this event successful. Now, may I request Professor Jasmine Banu Madam to conclude this session.
Thank you for Dr. Diva to request to conclude the session. We are privileged for getting the participate in such a well-organized awareness program on a topic that is a burning issue nowadays. Thank you for the organizer, the participant, and the Professor Shala Madam, and also the Gulshanara Madam and the Rokia Madam, and sharing their valuable insight with all us. And hopefully these are amazing endeavor to continue the further to betterment of the woman health in around the world. And thank you all, and conclude the session.
Thank you, madam. Good night.
Thank you very much. Thank you, our
all.
audience. Thank you all.
Okay, madam. Good night. See you some other
Good night.
Thank you so much for giving.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our